I'd like to introduce Mark Moran, who's the Chief Executive from Hydrate for Health. And he's going to be talking today about some physical hydration solutions.
Okay, hello everybody, that's me. So I'm Mark Moran. I'm going to talk about, as Leslie said, physical hydration solutions. And thank you very much, Leslie, for inviting me on here. Hopefully I've got something useful to say. So I was a spinal patient, and during my recovery, I couldn't believe there wasn't a simple gadget that would enable me to actually get fluids without having to call for help, because I literally could not reach the jug on the table next to the bed. And this is certainly far from unique. Once I discovered the scale of the problem, I quit a very well-paid corporate job and have spent now nearly 20 years, which is pretty unbelievable, trying to do something about it. And it's been one hell of a journey. So could we have the next slide, please? So there's a lot of brilliant work being done to address the issues of hydration in healthcare. And when I say healthcare, I'm actually talking broadly rather than specifically. So there's three locations for healthcare, really. You've got the in-care at home, you've got the care homes, and you've got the hospital network. And loads of work's been done. A lot of it's around what kind of drinks, how to make things attractive, reminding people to drink. And there's been an assortment of gadgets have come out and sort of unfortunately faded away that ring bells and fire lights and report to computers. But fundamentally, for me, I think one of the biggest bit that is missing is the question of access, independent access, not just access, independent access. And I think there's just three questions to be asked. Can the patient, let's call them, or the person, can they reach the drink? If they can reach it, can they lift it? And if they can lift it, can they actually hold it? Because, you know, for example, conditions like Parkinson's, they might be able to reach it, they might be able to lift it, but then because they're shaking so much, they can't actually hold the drink to their mouths. And fundamentally, if the answer to any one of those questions is no, then the patient, the person, is reliant on somebody being there to help them get a drink. And unfortunately, there's quite a big gap in terms of the percentage of time people are available to help these people get help to drink. So next slide, please. And here's a couple of numbers. And I'd like, if you can, to please trust me that the numbers are broadly either from the NHS or from the wider media. Basically, over a quarter of patients in hospital right now cannot help themselves to fluids. They can't reach it, they can't lift it, they can't hold it. That's 30,000 people, actually more than that, right now, every day, that are unable to get fluids. In the community, it's a lot more. I would argue, based on what I now know, that dehydration is possibly the biggest single issue in healthcare, but it's an insidious, hidden sort of issue because you can't see it. It creeps up, whether it manifests itself as a fall, as a UTI, as skin conditions, as kidney problems. It is massive. And I would absolutely argue one of the biggest causes of it is people simply can't access fluids on their own. There were figures out a few years ago saying there might be 40,000 deaths a year due to dehydration. This came from some work that was being done on kidneys. But basically, anybody who is in a healthcare situation who's not able to reach fluids independently is at serious risk. And quite often in a hospital setting, they're going to end up on an intravenous drip for rehydration. And mind-blowingly, well over 50% of intravenous drips that are put on for rehydration are completely avoidable. This is a massive number. I would go almost as far as to say it's scandalous because of the risks involved with putting somebody on a drip. but also for the massive increase in costs when actually all they need is a bit of help to get some fluids, whether that's nursing or care staff helping them with a glass of water, or other means, which is what I'll come to now. I'll come back to the costs of the drip because it's quite mind-blowing. So as I said earlier on, we've done nearly 20 years of this now, which is incredible. Next slide, please. And what we've been trying to do is basically deliver solutions to the problem that I've described. So enabling people to just get a drink on their own. 2 products that we've launched, both are available across the NHS. Both have been involved. Well, the hydrant has got a Queen's Award for Enterprise for Innovation. As you can see, there's some letters after my name on the screen, which is very, very nice. And that's because of this work. It's a big issue. The water drop was part of the the NHS National Innovation Accelerator under Stephen Powis, the medical director of the NHS, a few years ago. Unfortunately, it was during COVID, so we didn't actually see that doing what we hoped it would do in terms of spread and adoption. But the fact of the matter is, these products are out there. I'm going to show you a couple of slides now, just so you can, if you're not already aware of what they are, there's some pictures here of both. So this is the hydrant, and probably the best picture to look at is the bottom left-hand side, where the hydrant is just clipped to the hospital bed on its own there. This is a ridiculously simple, but actually very innovative product. The idea is it's got a clever clippy handle thing. You can attach that by just opening that clippy handle thing out to a bed, to a chair, to a wheelchair, to a drawer handle, to a drip stand. Basically, you can attach it somewhere around the patient to enable them to get independent access to the fluids. Very, very simple, cheap. You can clean it, and it's a low-cost, high-impact innovation, basically. And I'll come to the impact in a minute. But when we, a few years after launching the hydrant, we realised possibly one of the issues where we hadn't seen the massive levels of uptake that we thought, because this product or something like it, so let's not just talk about our product, maybe there's another product out there, I'm not aware of it, but a product like this enabling independent access should basically be in a couple of them in every ward, in a cupboard. And when Mrs. Smith comes in and we see that she can't get a drink on her own, but she doesn't need to go on a drip, let's sort her out. Operationally, the hydrant goes through the same process as your jug. It goes in the wash, it gets cleaned, it comes back. You do have to change the tube every day for infection control purposes in hospital settings. At home, they'll last for years if you can keep them clean. So we're doing a bit for the environment. Excuse me. I had a COVID jab yesterday and it's affecting me. So this is the hydrant. I should have put a title on it, but I didn't. Next slide, please. And this is the water drop. Again, ridiculously simple. It's an intravenous drip that you put in your mouth, if you like. Very cheap, very effective, single patient use, 24 hours only. I designed the hydrant first because, and for it to be reusable, because I hate waste, but I acknowledge that the NHS actually revolves around open it, use it, and throw it. And that's really what the water drop is all about. You open it, you use it, and then you chuck it out, which is shocking in some ways. However, when we start looking at the reduction in intravenous drips for rehydration, it's quite astounding. And I'll come to that in a minute. So next slide, please. So they both deliver 4 things. The one that should be the most important, and I say this as a former spinal patient, is dignity and independence. If you can help yourself to fluids whenever you want, you're likely not to get dehydrated. If there's any impediment to you doing that, and even if it's frankly, you just can't be bothered. It's too much effort, even though you could do it. You're at risk of getting dehydrated and all the things that that implies. There are massive efficiencies within the system where if I'm now able to take care of myself for fluids, I don't need a healthcare person there helping me, I don't know, for 45 minutes a day to get fluids down me. It releases time to care, which is a big issue. There are some huge potential cost reductions at scale, which I'll talk about in a minute. Excuse me. And the reduction in plastic use, and bearing in mind the NHS has got a net zero target, this should be the poster child. Either of these products should be the poster child for reduction in plastic in the NHS, because it's over a 70% reduction in plastic use versus using an intravenous drip for rehydration. And on the next slide, I'm going to show you some just ridiculous numbers. So here's the next slide. So this is the NHS's own numbers under the programme I mentioned earlier on, which is from under the direction of Steve Powis, the National Medical Director of the NHS. Part of the programme was to do an economic analysis, or an economic assessment, sorry, of the impact of the things that were involved with that programme. And here's the numbers for the water drop. An intravenous, this is, how to explain this? It's sort of like a time and motion study was done to do the economic assessment, and it was looking at the total cost, which is not just the cost of the product, but it's the time involved, it's training, it's moving stuff around, it's disposal, it's risk, and all the rest of it. And the cost for an intravenous drip for rehydration for 24 hours, 370 quid. I mean, you've read these numbers while I'm talking, so I probably don't need to talk to them. And that cost reduction is insane. And if I can just put it in some perspective, the Southmead Hospital in Bristol, where I'm based, put on over 100,000 drips for rehydration in 1 year. I've extrapolated numbers up to say, right, what if we managed to stop 10% of the drips for rehydration across the country that are avoidable? Let's say we only stop 10% of the avoidable ones, and it would save, based on these numbers, which are the NHS's own numbers, it would save the NHS considerably more than £1 billion a year. And at a time where today there's been a big announcement about efficiencies and all the rest of it in the NHS, and league tables and this, that and the other, why would you not want to get something like this that's so easy and so cheap and so simple to implement and so effective? Why would you not have that across the piece? And what I would also say is, these numbers are from within the NHS hospital system. If we prevent admission in the first place with a UTI from somebody with motor neuron disease, or actually multiple sclerosis is our sort of biggest single user group. Broadly, you save the NHS about £10,000 per prevented admission. The numbers are massive. So huge cost reduction, huge plastic reduction. 2 more slides. Next one, please. So this is just to let you know everything is available through the NHS supply chain. It's in the system. The codes are just on there. Of course, you can get them directly from us as well. And the hydrant is also available on Amazon. You just need to look for hydrant drinking system. My contact details are there, websites are there. We should be making a much bigger impact than we are, and there's lots of reasons why it hasn't happened at the scale that it should happen at. I'm hoping speaking at events like this will help massage things forwards a bit, not because I'm thinking I want to be a multimillionaire, but actually this is about need. There is a massive need, and if it's not our product, it needs to be somebody else's. It's actually that simple. So that's me. Last slide, please. I don't know if there's anybody out there who wants to ask questions, but I'm very happy to answer them. Otherwise, thank you very much.
Oh,
Oh,
oh, thank you. I guess people can send you an email for those that watch later. I think that was really, your presentation was really interesting because it so reminds us of the importance of hydration and also a nod to the costs of preventable dehydration. You know,
yeah.
we've got to watch it, haven't we? It's the same as preventable malnutrition. We need to make sure that these things don't happen.
Yeah, I mean, I was gobsmacked at the numbers, Leslie, when they were presented to me, the numbers I've just shown you. Honestly, I mean, I'd done my own numbers and come up with stuff, and then I cut them back a bit because I thought that looks a bit too ambitious. But when they came back from the NHS, I phoned them up and said, are you kidding me? You've got to be joking. It can't be that massive. And the bit that doesn't come out in those numbers is in terms of the preventing the drip, is there's no consideration given for the massive increase in risk of further infections from a
Mm,
new cannula going in. But
yes,
actually,
that's right.
this is probably more your environment, Leslie, in Age UK sort of terms, is prevention. Keep people out of hospital in the first place.
Well, we must. We can't afford to have people admitted at all.
No, we
I
can't.
think Helen has we got a question, Helen?
Yes, please. Thank you, Mark. That was really interesting. I'm not aware of either of those interventions, and they would probably be quite useful for the patient group I work with. I just
Yep.
wondered how prevalent they actually were in NHS hospitals.
Excuse me. Sorry, this is a COVID jab. Hi, Helen. Yeah, firstly, you've got my contact details there. If you want to ping me a note and an address, I'll send you a few to play with if you want. Otherwise, buy them through the normal channels, but I'm very happy to send some to play with. I know I can see there it's the ME group. We do have quite a lot of ME users, so very, very happy to help with that. In terms of across the NHS, we're probably in total, I would say, in 70 or 80 hospitals. But it's been, this has been the hardest thing I've ever done in my life, dealing with the NHS. And the difficulty is, and this isn't remotely unique to us, we've got a very, very simple product. We're getting anything new introduced into a system that, quite frankly, every day is firefighting, every day is whack-a-mole, trying to get something new in there. Even if you says, right, there's a Strepsil. Let's just pretend for a minute that yellow Strepsil is the incredible new drug that prevents all hospital-acquired infections for 50p. Even to get something like that in and sustained and used every day would unbelievably prove difficult. And what I found bizarre is, and we were massively well supported with this from very high levels in the first few years. We rolled it out in projects across, I don't know how many hospitals, a lot of hospitals, and it was all funded. And the frustration, the idea was that you roll it out in 3 wards and then it spreads to the rest of the hospital. And even now, as I said, well, we're coming up for 18 years doing this. I'm slowly, after 18 years, seeing, for example, there's a hospital in Coventry that's using them, and I'm starting to see another ward and then another ward. So people are starting to talk about it, but it is at the speed of a glacier. And I honestly don't know what the answer is, because we've had coverage, media coverage, we've had awards, we've had attention paid to us that far exceeds the size of this tiny little company. So if you've got a magic wand and you know how to make things happen in the NHS, that'd be great. I'm tending to let the NHS hospital side take care of itself and focus on the community, because I think we have a bigger impact with prevention. Which is much more important. So we're sort of trying to do both. But it's weird, like you've just said, you've never seen these before. We've been around for 18 years. We've got all sorts of noise behind us. If you just Googled the hydrant or me or whatever, it's like there's tons of stuff out there. But of course, these days, that is, any noise we make is drowned in so much other noise that people just switch off to it. So
Yeah.
it is a challenge. It's a real challenge. I mean, and again, not remotely unique to us. I've seen some incredible, absolutely incredible bits of equipment that have had millions and millions spent. They've got all the all the things they need to have, all the proof and everything, and they've just fallen by the wayside because I think it's because what you've got is a system that we all know is creaking, and is literally right. What's happening today? What fire do we need to put out? There's no room to take a step back and look and say, well, hang on, here's something that actually is going to save us time, which is going to free up time, which means good things, right? So anyway, I'm jabbering on.
Thank you. Yeah, do jabber. You're doing a good job.
Thank you.
Thank you very much. Thank you for your presentation and for joining us and your time.
Okay, am I done?
Yeah, you can go now. Bye-bye.
Hi, thanks, Leslie.
Thanks, Mark.